The coronavirus pandemic has surfaced a convergence of conversations and information sharing across multiple health and healthcare disciplines. Experts from public health, medicine, nursing, epidemiology, big data, engineering, and more have all found benefit from each other's knowledge and laser-like attention to solving problems as quickly as possible. Quality improvement methods, whether or not they're labeled as such, have also figured heavily in daily and nightly huddles and real-time attempts to execute and evaluate a lot of innovations and interventions, be they experimental treatments for COVID-19, testing methods, or the need to expand hospital beds, staff, equipment, and protective supplies. So what to make of perhaps this unprecedented, almost organic, multidisciplinary approach? Is it going to remain part of the fabric of health and healthcare going forward? All these interconnections with quality improvement, will they continue, especially with recurring infectious outbreaks and new pathogens to contend with? So that's where we'll turn our attention today. We're going to be grounded in guidance from infectious disease expert Dr. Don Goldman. He is Chief Scientific Officer Emeritus and Senior Fellow at IHI. And we'll have sense-making from Don Berwick and Derek Feely. They're our regular expert panelists on these virtual learning hours during COVID-19 pandemic. Let me pause there and say hi to the panelists. Hello. Thanks to all of you for making the time again to share your expertise and perspectives. A big thank you to our audience. As usual, you're going to hear from our panel for about the first 30 or 35 minutes, and then we're going to turn to Q&A and discussion, and feel free to chat in questions and exchange ideas throughout our hour together. And just remember, chat to all participants so everyone sees your comments and questions. So we're going to start with some table setting from Don Berwick. Don, what makes right now a good time perhaps to be thinking about these connections between epidemiology and quality improvement? Welcome, Don.
Thanks, Madge. Can you hear me okay?
Absolutely.
Now, I am really excited about this session, and I think it has to do with science. I always think of IHI as a scientific organization at its heart, and here, just as you said, Madge, there's a convergence of different sciences all around the COVID-19 pandemic, but we can learn from this. We can look backward and forward and really get smarter about how to deal with threats like this. I think there are 4 sciences involved here, and our guest, Don Goldman, is an expert in all of them. He's really got more than a hat trick here in terms of his own background and scholarship. I regard Don as a dear friend and a very, very close colleague, as we have been for many years. So the sciences I have in mind are, as in the label of this session, there are the biologic sciences, the infectious disease sciences and related biology of the virus, the biology of disease itself. Don Goldman is a professor of infectious diseases at Harvard, and he knows this cold. The second is the quality improvement sciences, the way we're approaching improvement from the disciplines that we've learned over the past century, really about how to deal with systems. And Don, again, is a master teacher of the quality improvement sciences. The third is the science of epidemiology, that branch of public health, which has to do with large-scale data and the movement of illness around in populations and the dynamics of that. Again, Don is a teacher of that. And the fourth, that's a kind of sleeper with Don, is history, because this is not the first pandemic. We've had others before. And Don is a teacher about the history of pandemics. So take history, biology, quality improvement, and epidemiology, and they all come together in this in Don's head. I think it's a real chance to learn about how to protect ourselves as a public and a population, even while we deal with this horrific crisis here. So I'm really excited about this session. As I think you know, Madge, in our polls of attendees of the virtual learning hour, I believe this is now the #1 rated topic, the most commonly asked for topic to be addressed, and we've got the right person to address it. So I'm going to get out of the way here and listen and learn, and thank you so much.
All right, Don, we look forward to some of your reflections as we hear and get to the meat of our topic today. Derek, why is now the time to lean into improvement. And as I said, whether or not you call it quality improvement.
Well, thanks, Madge. And we've talked a little bit about this in some of our previous sessions. And today I thought, in keeping with the historical context, I would go back to Deming. And I think at times of chaos and stress and in Deming's language, crisis, we need a way to organize our thinking and balance the need for both activity and reflection. We need a lens through which to look at the challenges, and I can't think of a better perspective to take than to use Deming's lens of profound knowledge. At times like these, we need to understand the system within which we work and the interactions within that system. That will help us to avoid unintended consequences. And so an obvious current example would be if states go ahead or countries go ahead and end social distancing in pursuit of economic benefit, that will have consequences because it's part of a wider system of interactions. This helps us to think this kind of approach, quality improvement approach, helps us to understand that if we try to fix problems without understanding the system that caused them, then there's a likelihood that things will get worse rather than better. And we also know that our current system is causing variation. The impact of COVID-19 is not equitable or just across our system, and understanding that variation, I think, is going to help us to respond to it. And we'll explore today, with Don Goldman's help, some of the knowledge that we'll need. Aren't we going to have to learn our way through this? And can we accelerate our learning by making some predictions and testing our theories? And finally, if you go to the next slide, this idea of human behavior and the psychology of change is likely to be really important. Won't our response be enhanced if we understand how people are thinking in this crisis, how they react to change, how are they going to find motivation, and how are we going to create a sense of agency that gives people both the courage to act, the emotional resources that they need to choose to act, and the power that they need to have effect, the ability that they can find to act with purpose. And so that's why I think quality improvement remains vital in these times, Madge. This is, as we've said before, not a time to revert to old-fashioned command and control, but rather a time to deploy some of what the students of quality improvement have been teaching us for some considerable time.
Thank you so much, Derek. And again, we'll swing back to Derek also for some reflections as we now turn to Dr. Don Goldman. Don, I don't know if you remember, but you and I probably started at IHI around the same time. I think we were both wandering around a little lost, but this is a space that we're in today in which you're not the least bit lost. You often say you got engaged with QI because you wanted to encourage the use of epidemiological principles and data to understand and solve systemic healthcare problems. So that's been a current for you. What's that meant historically? And then we'll kind of pivot to what's happening now. Thanks again.
Well, thank you, Madge, and thank you, Don B., for a very gracious introduction. It may be the best introduction I've ever heard about myself, so thank you very much for that. It's interesting that you should mention being lost, because I think all of us feel a little lost, almost in a duality of reality, and so I appreciate your bringing that up as well. So I like to always start by making sure everybody's on the same page. And what is an epidemiologist? My mom used to think I was an epidemiologist, which had a certain element of truth to it. But an epidemiologist simply uses data to study patterns of diseases in a population. And when we see an unusual pattern of disease, we try and figure out what caused it and to define possible approaches to getting back to normal, just as we're doing now. And an epidemic or pandemic is frankly game time for an epidemiologist. I get really excited. I'm sorry, but this is game time for me. And this pandemic is sort of like the Super Bowl, because getting the epidemiology right as quickly as possible is really a matter of life and death, as we all know. So um, epidemiologists like to look back in history, and there are two pivotal moments in the middle of the 19th century I'll just briefly review because they are relevant to what's going on today. And the first one, which you see portrayed on the slide, is Ignaz Semmelweis, who noticed that maternal mortality, which by the way is a huge problem, as we all know, in the United States and globally now, but he noticed that the mortality rate was much higher in one ward than in another, almost 3 times higher. And in fact, it was actually higher than it was in moms who gave birth on the street. And those moms were trying to get into the hospital to the ward that they knew had the better mortality rate than the one that didn't. And some of them would rather give birth on the street than go to the bad clinic. The main cause of death was childbed fever, or we now call puerperal sepsis due to group A strep. And the only difference that Semmelweis could discern between these wards, that in one of them with a high mortality rate, the doctors and the medical students who supervised the deliveries were coming from the autopsy room where things were highly contaminated and then doing examinations of the moms, whereas in the other was run by midwives. And we know how wonderful midwives are, and they didn't have this trip to the autopsy room, and they had this low rate of infection. He couldn't find other differences. The things we worry about today, crowding, climate, socioeconomic determinants, all that seemed the same. The only difference was coming from the autopsy room. So he asked the doctors to put their hands into a solution of chlorinated lime, the first hand hygiene experiment. And you can see, it's not technically a control chart, but from the back of the room, you can see there was an enormous improvement in mortality in the clinic that was run by the doctors. So that was really pivotal. Unfortunately, his work was ignored for decades. And my theory is that he didn't know how to explain data. And those of you who watch the briefings and whatnot on TV know that sometimes the data is presented in a way that I can't understand. And I doubt that the average American can understand. And Semmelweis had that problem. And he was also Hungarian. And he was in Vienna, and Hungarians weren't considered to be as prestigious and knowledgeable as the Viennese. Not much later, again in 1854, a terrible cholera epidemic hit the Soho region, currently Soho in London, if you've been there. And John Snow, often called the father of epidemiology, went door to door to try and figure out who was sick and to figure out where they were in relationship to drinking water, because that was his theory, that contaminated water, not foul air, not miasmas, which was the prevailing theory at the time, but the water spread cholera. He didn't sit in an ivory tower at the Harvard T.H. Chan School of Public Health behind a computer. He had shoe leather epidemiology and went out to really find out what's going on. What's missing sometimes in the United States and globally, people sit in a room with computers and they look at models and they don't go out and actually touch the people and see what's really going on there. Anyway, he constructed the famous spot map that you see on the slide and showed that cases of cholera were much nearer the Broadway the Broad Street drinking water pump than they were to other pumps. And he took the handle off the Broad Street pump and the epidemic ended. It turned out that actually a baby with cholera, the waste of that baby had been contaminating the Broad Street pump, and the epidemic probably would have ended anyway. But this is the dramatic moment in the history of epidemiology. It's ironic that one of our great heroes, Florence Nightingale, you all revere, as do I, remained a proponent of the miasma theory for years after John Snow proved it was cholera was borne by water. So we're resistant to these new ideas. So how are these fundamental epidemiologic principles helping us today? What has this got to do with COVID-19? Well, fortunately, epidemiologists such as myself are benefiting from much better data, though I have to tell you that without adequate screening and case finding, we don't have the data that we really need to predict what's going to happen in the future. It really remains a problem. But you've all seen the graphs tracking the course of the epidemic and how it's spread across the globe. And now we have genetic epidemiology. We can sequence all of the RNA, the nucleic acid of this virus, and we can track slightly different mutated strains as they travel around the world. And we know now the first case was in California. We can trace that with epidemiology and genetics in a way we never could before. You've probably sick up to here with models predicting what will happen in the future, and these are constructed by epidemiologists. But I'm always telling people those models are only as good as the data that goes into them. Without good screening data at a population level, those models will never be as good as we really like them to be. Another use of epidemiology that you're familiar with every day is it helps you determine who is at greatest risk of hospitalization. Who's going to need a ventilator? How many ventilators do you need? How many hospital beds do you have to stand up? And we know, for example, that people like with gray hairs like me and Don, I'll include you in that, you look like you have gray hair, we're at greater risk even without diabetes or pulmonary conditions or heart disease. And as worried as I am about myself and about Don, I'm actually more worried about Black and brown Americans because epidemiology has shown us that they are at totally disproportionate risk of getting the disease and having adverse consequences and dying of the disease. And so are Native Americans. COVID-19 is ravaging Navajo Nation as we speak. We're also the folks who look at emerging data from drug trials. So when the president or Deborah Birx gets up and talks about hydroxychloroquine or whatever, we're the guys who have to look at that and say, how good is this evidence based on the data we have now? And when are we going to feel that this is or is not a treatment that would work? And finally, we'd like to be at the table, and sometimes actually we're not, when folks discuss, should we reopen the economy? Should Georgia really reopen its economy today? Those are epidemiologic decisions as much as they are economic and social and ethical decisions. So there's a lot that we do that I think helps. But here's the rub, and this is really, really important. The best epidemiologists in the world can give us great insights and guidance, but our forte, well, Don thinks I'm a four-headed monster, and maybe it is my forte, but for many epidemiologists, we don't take action that takes care of patients in a better way and saves lives. We just point the way, and it's up to people like you on the phone who are really going to translate the epidemiology into action. And I've been so impressed that the organizations that are really nailing this, that are dealing with unbelievable challenges and still making progress and saving lives, are using the kinds of techniques that we talk about all the time. They're using agile, real-time testing in the environment that's in front of them so that they can improve the systems of care, create standardized clinical pathways and supply chains, all based on their testing and learning. I've never seen such agile, rapid learning in my life. PDSAs by the hundreds of thousands are going around the country. Derek mentioned command and control and incident command, which I think is really, really important, but only if we use quality improvement thinking to have clear priorities, create standardized care systems, and have really, really good communication. We have visual management, team huddles, SBAR, all these tools that we teach and learn together. And finally, we're really patient-centered, and we prioritize not just the families and patients whom we serve, but the people who come to work every day to try and help those folks as best they can, and at great peril to themselves. So these are all the elements that we teach. It's what you do. These are the practices and the skills that in calmer times we deploy. But if we really are good at it and we practice in calmer times now in an emergency, they're part of our muscle memory. We can actually go out there and make a difference. So I'm inspired to be an epidemiologist who gets to work with people who do things and make lives better and save lives. So thank you. Thanks for listening.
Thank you so much, Don. I want to just pause for a moment. Again, thank you, audience, for some of your questions and comments, which we'll get to in just a few minutes. I wanted to, just as we move along, Derek and or Don Berwick, any reflections on anything you've heard? And then Don Goldman will pivot a little bit more to this reopening question, and actually maybe a little more about what that means for health systems also. So Derek, any thoughts as we're listening right now?
No, only Madge to thank Don for his presentation. And what it reinforced for me is that those 4 scientific disciplines that Don Berwick attributed to Don Goldman at the outset, what Don's messaging reinforced for me was that these are not entirely separate disciplines, that they overlap and intersect, and there must be real learning to be achieved where we can bring those disciplines together and bring them to bear in the current environment and situation.
Thanks. Don Berwick, any thoughts?
Well, thanks, Madge, and thanks, Don Goldman. I'll pick up on 2 points that Don mentioned. I want to urge us all to drill down on the racial disparities data. It's not surprising given our knowledge about the legacy of racism and inequality in our country, but it's playing out in a very dramatic form in disparities and outcomes. And perhaps we can talk more about that in this session, and I even devote a further session to it in the future. It is really shocking. Maybe Don Goldman could comment further on that. Second is a technical issue that has come to my attention that maybe Don Goldman will speak about. I've been asked more than once the following question: given the urgency of the COVID epidemic, isn't it true that we don't have time now for quality improvement? That's for later. That's a set of sciences that are slow moving and we have projects and all that. I think exactly the opposite is the case, as Derek was hinting in his opening remarks, and we can explore a little more why the lens of profound knowledge that Don Goldman and Derek referred to, why this actually is a highly adaptive way to look at the problem and how we're going to address it in very fast cycles. So those are two points I'd like to just leave on the table, and perhaps we can address them as we move along.
Yeah, Madge, do you want me to, Don?
Yes, jump right. Please address that, and then let's talk a little bit about, we'll get to all these rich questions from listeners and the ones that Don and Derek have just raised, and reopening too, but yes, go ahead.
Yeah. So Don, first, thank you for highlighting disparities. I happen to have behind me this book, The Color of Law, which is about structural racism in the United States and how it led to housing issues and lack of wealth accumulation by African Americans in the United States. And so this was entirely predictable based on everything we know about social determinants and structural racism in the United States. So that doesn't make it any less shocking. The one thing that I've honed in on, which is such an important aspect of the psychology of change and what we do at IHI, is communication. And I already kind of alluded to the difficulty in understanding the statistics and the epidemiology that are part of the briefings every day. But I just didn't hear and continue not to hear messaging that's directed at the average American, let alone the impoverished American or the underserved minorities of this country. And that's part of the quality improvement response, is to hone the messaging so that people at whatever level, whatever their health literacy is, can actually understand it and begin to act on it. So that's just a thought about that. And we've got to improve the messaging so that we're engaging those people. Secondly, the issue around quality improvement is for later. This is just so important. I learned a very valuable lesson trying to do a system process map around an issue that involves surgeons in my organization way back when I came from CDC to Boston Children's Hospital. I wanted them to sit down and have meetings and draw the map, and we were going to have it's going to be perfect, and it was taking weeks. And I finally realized that this didn't require weeks. I had to go to where they were and harvest their knowledge in situ. So I got up at 5 a.m. and went to see the surgeons in the OR where they were gathering and had the same crummy coffee and the same stale donut they had. and asked them where their role was in the system. So we don't have time in a crisis to do things slowly and by the book in some sort of methodical way. We need to be familiar enough with these skills that we really rapidly do the testing, build the systems, adapt and learn. And those people who've been practicing quality improvement all along, now they're in a position to really go out and do it. And the bonus of this is they will remember you on the call. If you're now using whatever quality improvement tool, whatever you call it, doesn't have to be called PDSA, call it an experiment. You don't say driver diagram, say that this is our causal diagram. I don't care. Just do it, and you will never, ever forget these skills because you're actually using them in crisis.
Okay. I'm looking at the, if people see my head going back and forth, I'm looking at Don, and I'm looking also, Don Goldman, and I'm looking at the chat here. Say just a couple things about this reopening issue that's on everyone's minds, and then we'll dig in, which will, I think, further to the chat, which will further amplify, I think, some of the themes already that have come up. But what about this? How to think about reopening QI and epidemiology here?
You want me to?
Yeah.
I feel like I'm talking too much, Madge. So this
No, by comparison,
you know me,
no, I'm
I
just
get
teasing.
going. So this is obviously really important, and we don't want to push aside the economic realities and the social issues, and frankly, the suffering of a lot of people in the country. And some of them are very eager to get back to normal. And what we seem to be doing is developing fault lines where people want to get back and they're going to do it, and they're going to protest, and people like myself who think that's not a good idea. But there is a rational approach to this, and it's like everything else. Remember, I mentioned shoe leather epidemiology, not sitting behind your computer. My worry is that there are a lot of important people sitting in rooms somewhere, virtual rooms, trying to figure this out in some logical way based on epidemiology or whatever. But they're not necessarily in touch with the reality of the people who are coming back to work. I'm working with a guy named Krishna Udayamaker at Duke, who's in their Global Innovation Center, a really smart guy. And he's developed a framework which would be very familiar to quality improvers. It's kind of supply and demand. The supply are the people that need to come back to work, the demand are the businesses to which they need to return to work. And on the supply side, he looks at the people coming back and he tiers them by their contagiousness, the risk they pose to others, and by the risks that they encounter based on their own condition and their own preferences. So I may be antibody positive and test negative, and everybody says you get a passport, you go back to work, but I'm old. And if I had pulmonary disease, I might not have the risk tolerance to say yes. So we have to take both of those into account. My living circumstances, how crowded is my dwelling? Do I live in a 5-family apartment with people recently immigrated, and or am I living in a penthouse in New York? All these things matter. The other side, let's take IHI. What does IHI need to do to reopen? What's the cleaning protocol? What is the screening protocol? Who comes to work? Who's essential? Who do we now know would probably work better virtually and not come down to 53 State Street? And that's all great. That's a beautiful framework. Quality improvement, actually patient safety, it kind of hit me like this when I was talking to Christian. I said, we have this tool that he didn't know about called failure mode effects analysis. If you're in good manufacturing practice, or you're making drugs or biologics, you call it hazard analysis, critical control point, or HACCP. They're the same thing. You look at your system and you say, where can it fail? How can we detect that it fails? And can we buffer it or mitigate it? Or is there going to be some horrible consequence if it fails? I like to tell the story of an ice cream manufacturer called Schwan in the Midwest that had a failure mode that they didn't detect and buffer, and 221,000 people in the United States get salmonella. So this is really critical. You make a mistake coming back to 53 State Street, and lots of people could be infected. Now, how do you imagine that? The way you imagine it is to say, who are the types of people, if you will, just to use a researchy term, who are the persona? Who can we make an avatar of, let's say, a housekeeper? who's going to come and clean the surfaces so that I, Don Goldman, and Derek feel you can be safe and you can come back and you'll feel secure. Who are those people? How do they get to work? What do they have to take care of before they can come to work? Do they take the MBTA and sit with all those people? When they come in the building, do they take the elevator along with me and 10 other people? When they get upstairs, does somebody really help them feel competent to clean the environment the way they do? And then how do they go home? And what happens if they get sick? And what is their family doing? And what are the consequences for them? So if you simulate, and we have people at IHI that are really expert in this, like Allison Perry, if you simulate what that persona looks like going through the system, you'll find pinch points you didn't appreciate. You may find that we have to send a car out to some place 3 MBTA stops and a bus stop away to bring people to work safely and supply them with masks and have them screened before they arrive at IHI, wanting to do a good job and wanting to help us get back to work. So, and I would do the same thing for an executive, a person living in privilege. What does that look like? And it turns out that I'm just as concerned as that housekeeper would be of getting on an elevator, 53 State Street, which those of you who take it know is a very hot, confined space without really good ventilation. How do I feel secure in that elevator? It's a failure mode, and we've got to figure out how to mitigate. I hope that
And in
makes
that,
sense.
yes, I think so. And please, audience, weigh in on Don's explanations, which I think are pretty clear. And what QI, Don Goldman, would bring to some of what you're talking about is we track it and see how it proceeds over time and what kinds of issues may come up that need to adjust the process, would be needed to adjust the process, and what might be some of the outcomes. So in other words, we're not just flying blind, let's try this, let's try that, and we have no idea whether it's effective or not. So I think that's one of the connections we're trying to make.
Yeah, and one of the biggest issues I see in students who I'm trying to teach quality improvement to is they think of PDSA as some grand experiment where Don and Derek imagine are going to sit in a room with me and we're going to figure out our big implementation test. And we go and run that test, and a month later we find out that 150 people got sick. No, Roger Resar, one of the great improvers and reliable systems experts in the country, taught me that when he wants to test something, he tests it on one patient tomorrow. And Don, you're always saying, well, can I try by Tuesday? Sometimes I push back on that because you don't want to just try anything. You want to try things that are part of the system and on the causal pathway to the outcome you want to achieve. But you start small, one elevator ride with 2 people, and we'll see how that elevator.
Okay, let's kind of transition here. Thank the 2 Dons and Derek for the first half hour here. As we continue, a number of interesting observations, comments. Vicki Minden helping us out here on the chat, getting as many links in here. Somebody just asked for an FMEA tool, and yes, we can share information about that. I think what I want, let's try one thing that would maybe just flow, Don Goldman, off of what you just said about how you might go about this. There's a question as we look at the issue of inequities and disparities here, concerns about unreported cases and maybe sort of tucked away in people's lives, circumstances, and also then part of a stream of people who may be unable to really protect themselves and those around them. Is there some thinking? You don't have to solve it on the spot
I'm not
here.
going to solve it.
No.
I'll just say one thing that I noticed that is a benefit of all this. I've never noticed the birds at my bird feeder before.
Okay.
and there's some birds that I've never. Some black bird with red wings. If anybody's a birder, you can chat it in. Tell me what that is. But this is a really profound question. We're certainly undercounting deaths. There are people dying at home. And we also have this other observation that scares a lot of people, including myself, of the steep decline in the number of people visiting the emergency department or coming to the hospital. And there, obviously, people are afraid. I don't particularly want to go to emergency department right now, even though I know they're well prepared to deal with what I have if I have a heart attack or a stroke. I'm really concerned that people are delaying seeking medical attention out of fear. And if you happen to be a Black and brown person in America, you may be delaying going because you also don't have a level of trust that you'll be taken care of equally. We have lots of data showing that African American people in the emergency department wait longer to get critical care than people who happen to be white. I once heard an emergency department doctor trying to recruit fellows to his program say, the one thing I love about the emergency department, we give equal care to everybody. Well, no, you don't. Actually, so regardless of whether you're fearful of getting infected or whether you're fearful because of trust issues or transportation issues or whatever, the use of the emergency department is definitely going down. That worries me. I remember a quality improvement project by a very famous organization. They presented to our scientific advisory group here at IHI, and they said, look, utilization in the emergency department by these babies is going down. Isn't it great? This was a wonderful success. And the question that came from one of our advisors was, how do we know they're not dead at home? And, he was really calling up what's your balancing measure. So we can be doing a great job in the hospital, a balancing measure here, who is dying at home, who isn't coming, who needs to come, and how do we message that? And finally, I'm beginning to see messaging now, including advertisements from the Boston hospitals. We are ready for you. Don't be deterred. We will treat you safely in this environment. Please, if you have a sign, especially with COVID, we now know there's strokes in young people and so forth. You've got to come in. It's really important.
Thank you. Derek, I want to bring you in for a minute to address this sort of a theme here, which is that just because all fabulous fields and disciplines and great minds and best intentions are applied to things doesn't mean the first pass is necessarily going to work out. And there has to be that space for learning. And yet, because so much is happening transparently now, it can look like, oh, that gets a black eye. Why did we ever do that to begin with? Wonder what your thoughts are about that in the context of anything being tried in this country or in other countries.
So for me, Madge, that raises two important sets of issues as we try and work our way through this. The first is, can we find a way to share the knowledge so that when people are building theories or they're creating a hypothesis, then they can do so in a way that's informed by the experience of other people. And IHI is trying right now to build that kind of repository. And at the end of the show, I'll give the listeners some links to that work. The second, I think it goes back to the point I was trying to make earlier about the importance of human behavior and the psychology of change in this time. And one of our colleagues, Jessica Perlow, has been on Twitter this morning tweeting about what's our psychological PPE during this outbreak. And I think we haven't yet paid enough attention to how can we make it as safe as possible for people to raise their hands right now and say, I'm not happy with this, I'm struggling with this, can you help me? And so those are the two areas I think that we might want to just focus further on as you say, learn our way through this. Firstly, can we do that in a way that can we do that as a collective, as a collaborative? And secondly, can we do it so that people feel safe in sharing the challenges that they're experiencing?
Thanks. And I think your points are really well taken. And I think part of what's happened in this pandemic, because there's so much life and death riding on various things, it can become easy to find targets and say somehow that was responsible. Let me turn to Don Berwick. Don, I thought this was the perfect question for you. Can QI help with the politics, particularly in the United States? So we'll see if you and I maybe one day can design a show on that. But something near and dear to you, Don. And then Don Berwick, and you also wanted to maybe pose a couple questions to Don Goldman.
Yeah, I mean, as my colleagues have emphasized, this is a time of enormous uncertainty. Most of the time, we actually don't know what to do. We have to learn our way very, very fast. And so that's where I see the quality improvement approach being so helpful. It's a way to get organized, to begin to say, all right, well, we have a question. Let's try this now on the next patient, and with a safety net underneath that. That agility, that ability to learn as we go is really crucial. That applies more, I think, at the clinical and organizational level. At the political level, we have rather long cycle experiments going on right now as states differ in their reopening patterns, as we see different levels of surveillance in different locations. And I hope we're smart enough as a country to study that variability and try to extract any lessons we possibly can from differences in policy. That also applies globally because countries are differing from one another in very interesting ways. So I really am encouraging a reflective attitude toward this and treat it as cycles of learning. If we don't do that, the learning will be lost, as it has in prior epidemics, where we're discovering stuff we should have booked long ago. My question to Don Goldman is technical, but it's topical. Back to your shoe leather. I want you to put your shoe leather hat on, if that's not a mixed metaphor. We have this interesting project in Massachusetts now where the state, in cooperation with Partners in Health, is going back to shoe leather epidemiology to go do case finding, even in the midst of the ambient pandemic, which seems a little counterintuitive. And now California is considering doing that. Can you explain that? It was written up in a wonderful article in the New Yorker this week by Jim Kim, who describes the whole thing. But maybe you could take us to school for a minute, Don, about what is going on there and what's the promise or the risk of that kind of case finding effort. What is it?
Yeah. So case finding and contact tracing is one of the core principles of good field epidemiology, and we use it all the time for tuberculosis. We use it for sexually transmitted diseases, HIV/AIDS, and it's something that's in the background. And one of the sad things is in the United States, we've underfunded public health so that the manpower, woman power, skill set to go out and do it is not where it needs to be to ramp up in a time of crisis, but it's absolutely fundamental. It does require a tool to screen. So if you don't have a screening test for tuberculosis, HIV/AIDS, malaria, whatever it might be, you can't go out in the field test and know who's infected and who's not. So it's got to be
case finding mean, just to bring.
Yeah, so you can go out and ask people about fever and take their temperature and there's what's called syndrome. But if you don't have a test to determine are they really infected in a disease that has a substantial rate of very minor or no symptoms at all, and yet you're contagious, then you're kind of hamstrung. You can't really do field epidemiology and case finding. So these folks, in addition to going out and seeing who's sick and where they are and tracing their contacts, have to have in hand a way to determine, are they infected or not? Are they immune or not? And we're not there yet. The idea of a field force going out and doing this is critical. It's most powerful once you get the disease under some control. That's why not prematurely opening up and having a resurgence of infection is so critical. It's really hard to contact trace when you have thousands of new cases every day. You'd be running around like a Brownian movement. There's one. You'd never be able to do it. When you get down to a time where the number of infected cases is truly declining, and every day you have a manageable number of patients and people you can visit and screen, then you can contact trace and do what we did in the early days, when unfortunately we didn't realize that it was already too late for that methodology, already spread widely in the community. But this is going to be essential in opening up and keeping open. Keep open up. It's widely used. If you were to look at tuberculosis, for example, in Africa, contact tracing is absolutely critical in smallpox eradication. that was the key. You find people who are infectious and you vaccinate around them. So this is a really important effort, especially if we get the disease tamped down a bit. Partners in Health, by the way, which is the partner in Massachusetts, Jim Kim's old organization, is very, very good at this. They've honed their skills in Rwanda and other places.
More about the initiative and what they're involved in. Don Goldman, do you fear or worry that with all the pressure around this reopening, the economic losses across the board, health systems, having had to grind a lot of other services to a halt, that the thoroughness of what we're doing now might be compromised? In other words, that people's ability to sort of hold this space. It's not that we maybe can't do a few things at the same time, but part of what we're witnessing is the richness of what's coming about by an amazing focus right now. And I'm sure many people are wondering, somehow, how does this keep going, even if we start to modify things?
Well, first of all, there's exhaustion, right? And we haven't really talked about the mental health burden that comes along with this. We're not really talking about people who take their own lives, people who are in deep depression, people who ought to be seeing a counselor or a psychiatrist, but they don't have a Zoom connection to do it. So there is this toll that an outbreak like this takes on people over time. You just can't keep going at pace indefinitely. Also, at the heart of this, I think if I'm interpreting you correctly, is are we going to learn the lessons we need to learn, or are we so distracted that we're just going to bumble through and do the best we can? And there's a real tension here between rapidly testing and learning versus learning durable lessons that will serve us in the longer run. I'm often asked the question, as I know others are as well on this call, people say things will never be the same. Well, what won't be the same? And are the things that are going to be not the same? Are we going to be better? Or are we going to be worse? I mean, we could discuss, for example, whether disparities in the United States will be better or worse after this. So what we learn has to be strongly enough supported that it's durable and helps us going forward. I was speaking, and I don't think I'm doing this out of school, but I had a phone call with Gopal Khanna, who's the director of the Agency for Healthcare Research and Quality yesterday. And he's thinking about how we can learn rigorously using scientific methods closer to real time. So traditionally, AHRQ puts out a request for proposals. They're due 6 months later, the money's 6 months after that, and then you get stuck, and 3 years later. Well, we can't do that. And so they've accelerated their process now where the money's given out much, much quicker. But that's still, to me, and he knows this, it feels too late. The key learnings are happening in real time and will be difficult to retroactively pull out. So I don't have a good answer to that, except that I would love to see more effort, both globally and nationally, to understand the lessons. We're all interested in telehealth, but there are other lessons here about how you organize a response, how teams work under crisis that we really need to learn. We have a global scientific community working on vaccines. We have a global scientific community working on the virulence properties, the spike protein of the SARS-CoV-2 virus. That's great, unbelievable transparency, including, by the way, from China, which has been feeding enormous amounts of data about this virus to us. I don't know, and IHI can play a role here, how well we've incorporated an international global community to find those lessons that, in fact, are worth learning and preserving. We're better at doing that with pure science than we are with improvement and implementation science. And in terms of the politics, Don, you were and Madge, you asked about QI and politics. There's something here I just wanted to say, and it relates especially to disparities, but I think it relates to all aspects of the political dialogue in the country. And it's really hard to do, especially for some of us who have been successful in the world, and that's humility. And those at IHI, Amy Reed, Dorian Burks, others working on equity issues are constantly talking about cultural humility. And it's not a difficult concept. It simply means that you are humble about what you know, what your lived experience is, and are curious to know what other people bring to the discussion and have knowledge that you don't know. And it's a particularly lethal problem for scientists who have been successful, who have lost the ability to be humble and open to other people's lived experience. So that idea of humility, understanding the other person's point of view and their lived experience is just so important. And this is in any aspect of the political dialogue. It's really hard to engage. I've spoken to people who do a lot of canvassing. Don's family, they do a lot of canvassing, I think. And it's really hard to go up to somebody who has a sign on the lawn that is a different political personage than you support. But I'm always curious, well, just tell me why. And they may say, because I'm suffering, and that person has answers. And the answers may be wrong from my point of view, but the important thing is to hear the suffering involved, to hear what the representative of a poor rural community in Alabama has to say about COVID, or could say about hypertension, or about maternal mortality. Never mind their political point of view. What's our humility to understand their lived experience and what's driving concerns for their community?
Thanks, Don. I'm going to swing back to Don Berwick in a minute. Wanted to say something about the WHO. Derek, this may be a good moment to, when Don Goldman was talking about this, well, cultural humility and global learning, and what IHI has thrown some of its energy behind right now. And Rachel has a couple of slides there just to help kind of illustrate what we're talking about. And you all can take these slides with you.
Hey, Derek? Madge, just for spontaneity, before Derek responds, I'll tell you, my wife texted me, the blackbird with red wings, for those of you who can't wait to hear, is called a red-winged blackbird.
Right. Barbara Ballack and some others weighed in on the chat. Somebody said scarlet tanager, but I think red-winged blackbirds is correct.
I'm sorry to interrupt, but I'd love to, we're in the moment here, right?
Thank you. Derek.
Yeah, it's okay to interrupt, Don. It's only me. So I want to just signpost folks to a few things. So there's been a lot of interest in the chat on FMEA and driver diagrams, etc. There's a whole suite of those kind of tools on IHI.org. You can find pretty much any quality improvement tool you want, freely available on IHI.org, and indeed our kind of common tools page is the most visited bit of the website. Second, I wanted, before I get to the point that Madge wanted me to make, I want to also signpost people to a web page at IHI, which is called covidstories.ihi.org, where we're trying to bring the stories from the point of care to a global audience. So we want to hear the voices of the healthcare workforce who are dealing with COVID-19 day in, day out, and amplify those voices. And I think there's power in the stories that these people are telling us. And then the third thing is this IHI COVID-19 global community. This is the thing that Bernard Crump was talking about in the chat earlier, and Don Goldman just referred to. This is IHI's effort to create a community that can continue this discussion. And if you go to the next slide, please, Sarah. This is what we've created. It's a private online collaboration space created by IHI to facilitate rapid exchange of ideas, of approaches, solutions in order for us to accelerate the trajectory of this virus. There's already something like 30 work groups that have been created. They are either topic specific or they're region specific. And so you can find something almost certainly that's of interest to you specifically on the site. And if you go to the next slide, Sarah, you can see here how you can connect to this. And so I'm encouraging everybody on the call now to visit that website link, covid19.hivenetworks.com, register, use the activation code that's shared there, and then you can start to participate in this global learning community that seems to be at least part of what people are seeking as we try and share knowledge across the whole globe. And it really is already a very global community. One of the first regional sites that was set up is in South Africa. There's another one that's really active in Brazil. And so tremendous amount of learning already being generated through the community. So thanks, Madge, for letting me bring that to the attention of the people on the call.
Thanks, Derek. And we will get a link up there about how to take a look at what's going on with the story repository we're building at IHI as well on IHI.org. Don Berwick, I think you're going to get the last word. You were feeding off of some of the remarks about politics and what do we do with some of the acrimony? You wanted to say something about the World Health Organization. Go ahead.
Yes, I do, Madge. First of all, I'm so proud of what IHI is doing in the global sphere, and we are able to offer a tremendous amount of contact among organizations all over the world. You can see it on this chat. We have a guest from Vietnam, I notice. There is also an international structure for learning. Don Goldman was talking about the importance of harvesting knowledge, and that is the World Health Organization. There is only one. It's a unique asset on the planet. Like all large organizations, it has some problems but many successes. And I hate to be too political, but I just feel, I guess, outraged that we would do anything else than increase and redouble our support to the World Health Organization. This is a place that's supposed to bring us together. And so I just want to urge everyone on the phone to express their support and their commitment to this organization. It will get better over time. It has troubles, but it is absolutely essential. And maybe Don Goldman, I don't want to seize the microphone here, Madge, but maybe Don, who's worked with WHO, I know, would have a comment about that point.
Yeah, as they say on a lot of these shows days. Can you please say that in 20 seconds, Don?
Yeah, this will be 20 seconds. I think that even the CDC director would not support the policy of the government, White House, to withdraw funding from the WHO. He couldn't go there. He said we collaborated with them, we worked together. That fabric of collaboration is absolutely essential to world health. And we forget that there's an enormous burden, people dying by the thousands every day of tuberculosis, of malaria, of HIV/AIDS, and countless other diseases that WHO is actively involved in setting goals for. So I thought it was really ill-advised and counterproductive at a time of crisis. And everybody can improve. I can improve, IHI can improve, the governor of Massachusetts can improve, and so can WHO, but this is hardly the time to send that signal.
Okay, thank you. Don Goldman, Don Berwick, and Derek Feely. I was going to call you guys the three tenors, but I was a little afraid that maybe Don Goldman would start singing. So I didn't, but we have reached the end of our time together today. And as we wrap up, please take the poll that's opened on the right-hand side of your screen. We greatly appreciate your feedback. And if we didn't get to your specific question, do stay connected with us at IHI as we work on making more of what we're learning available. Rich amount of resources now on the website that will be continuous with many of the things we're talking about. Virtual learning hours are one of the free benefits of IHI's new membership program, and so we've got a few more that we're offering over the next few weeks. So we mentioned, well, I think it came up in the chat, telemedicine will be next week. We're going to talk about equity in a deeper way, of course, on May 8th, and then on May 15th, we'll be really taking a very focused look about where are we and what happens next. Don, and Derek, thank you again. Thank you, audience. Always gratified when I see you talking to one another, and I hope you'll continue those conversations. Look for the archived edition of today's show that will be posted to IHI.org no later than Monday. And we will be back next Friday at 10 a.m. We really wish you all the best. It's an honor. Talk about humility. For the Institute for Healthcare Improvement, I'm Madge Kaplan. Stay well, everyone.